Very much, audience. Thank you, Ernest, for the robust leadership you're showing here. Thank you for my friends, my brothers, and my brother and sister. For Sister Sylvia took this up, not knowing it where she was going, not connected at all. But I'm encouraged that she's agreed uh, to take part in this. But it's all Pastor Michael's fault that I've been caught up in this afternoon. However, it's a privilege to be on this platform. Can I have my slides showing, please? While that is coming up, can I just say that let's remember that when we talk about the patient, we're talking about body, soul, and spirit.
Hey, Pastor Henry.
Yeah.
Please, can you hear me?
I can hear you.
Yes, okay. Sorry about the interruption. We'd be glad if you can tell us something about yourself briefly.
I will.
Please.
I will in a second.
Okay.
Right.
That's right.
Yeah.
Okay.
So when we talk about the patient, the human being ourselves, we're talking about the body, spirit, and soul divide of the human psyche, or what is made up of. And by the time the patient comes to our care, most of them must have prayed for either deliverance or hope to survive, as well as good health care treatment and management, especially commitment and getting committed personnel and helpful people to look after them. Well, you will see from the first slide that spiritual care of the patient within the context of holism in nursing healthcare provision. I try to couple everything together, but I know it's a very broad subject, a very big area to talk about. Well, none of my colleagues actually took the trouble to write their titles, which I'm sure some of them have longer than myself. But at a very early age, I wanted to work in as a health professional, if possible, be a doctor. But be as it may, it wasn't long after I left secondary school that I had a scholarship to leave the country to study dental technology in Nigeria. And I remained in Nigeria for 15 years. I qualified there. I taught in the School of Dental Technology in Lagos, in Jos, and in Enugu. Now, I was just at the point of coming to Kolebutu in the dental school when I got another grant to come here, this time to do learning disability nursing. So I switched. I thought I wasn't ready yet to come to Ghana, and I was actually advised and warned. By then, they have not even employed a single, the dental school hadn't started, I was told. But I was coming February 1988. By that time, I switched and came to England. I'm not going to say more about that. But I did my RMNH, registered nurse mental health. Following that, while I was that, soon after that, I was hungry and thirsty for more knowledge. So I went into Open University, did some studies. I did some mental health, MSc mental health. I didn't complete it for various reasons, including childcare and so on. Then I studied the BSc honors for specialist learning disability, community health care. And I remained in the community working for over 20 years before I retired. Since retiring, I've actually lived a lot in Ghana, did the Master of Arts Theology, and currently doing the Master of Theology and writing my thesis on mental health and spirituality among Ga people. If you're a Ga, I will have a conversation to have with you one day, if the time comes. So that's my background, and at the moment as well, I am working with the University of Northampton in the dealing with people who are dealing with nurses regarding competency. I'll stop. I won't say more than that.
I think people are enjoying it. I'm enjoying it myself. I don't know. I know my colleagues are also enjoying it. But
Okay.
for time's sake, maybe we can do that. We can continue some other time.
Okay.
Some
Right.
of these things, the sharing of these experiences inspires some of us to. Yes, sometimes the experience you share
Okay.
inspires us as young healthcare professionals also.
Well, the title JP you see there is also because in my years here, I've spent more time trying to do things and help people than work for money. So I became a magistrate, Her Majesty's magistrate, and I stopped going to courts close to the time I retired because it was tiring to take 2 days of a month of my calendar and work to sit in courts. I can't talk more about that because the focus should be on spiritual care. So I accepted to deal with this particular topic because it's a topic of interest to me. Particularly when I was working in the community, I discovered that a lot of patients don't receive support to access their spiritual health care because the nurses don't particularly bother. In the UK, there's more of secularism here. Very few people are involved in religion in the real sense, and very few Christians as well. So they're not really bothered about including in their assessments what the person's own personal beliefs and cultural beliefs involve, and therefore the needs are not met. Especially when I work in community homes, and I know that was such a problem. If a Muslim wanted to go to mosque on Friday, it's easier than a Christian going to the chapel on Sunday. But that's the political side of it. And I actually did some work with the prison fellowship as well. So I know a bit of that. Before I became a magistrate, I was a prison fellowship visitor. Can I move on to the next slide, please?
Okay.
Right. Okay. So I've covered who I am from 1973 till date. My daughter put these things together, and she wanted to make it more interesting. So there you go. Now, these aims and objectives are not okay. Can we move on to to the next slide? Yeah. The aims objectives are not original to me, but I thought they fall within, they cover the topic, how I intend to treat the topic. So to raise awareness of the importance of spirituality and spiritual care for patients from the consultation room to the lounge, or the way we put it, I mean, the living room. To enhance your knowledge of the skills and techniques involved in providing spiritual care, and to enable you to feel confident in implementing spiritual care in your everyday nursing practice. Next slide, please. Now, I'm rushing through because 20 minutes is not a lot, but I thought it's important for you to have briefs. And then, as it's been said, we might be able to have some chats afterwards on the platforms that are being created, or even through
Okay.
yeah.
Okay.
The important thing there, you can see the word assumption is there. When it comes to spiritual matters, we must not assume anything. We must not assume the dressing, the appearance, the native tongue of anybody when it comes to spirituality. I've seen a question on the chat somebody asked, but that was directed maybe to the previous speaker, that if somebody came in and it's traditional fetish priest and he wants to be prayed for, would you allow that or something? The answer is yes. You have no business stopping that individual from accessing what they think best. If you want to have any private conversation on that, you can do that at your own risk, but you have no business. Okay, so you're looking at this particular diagram, and if you're able to capture some of that probably through your later on the videos, you'll see that it's giving us a very broad view of what spirituality covers. it's a key part of recovery, key part of caring for patients. It's key part. Like I said earlier on in my introduction, that for some people, yes, their problem may be spiritual. Their problem, or after everything else, they need prayer to get them through their situation. Or they are actually praying that they will meet a very nice doctor, or meet a nice nurse, or psychologist, or physio, and everything. And then they met you, and they're afraid. They need that assurance to go through these major health problems that they're going through. I was at Pantan not long ago, during 2017, when I was doing my research there. And I was told that they don't allow churches inside Pantan Hospital. And I wasn't surprised, because everybody wants to come and practice their religion, their faith on the patients, pray for them. And if they're not getting recovered, they tie them down and put them to prayer camps and so on. Very inhumane way of caring for people, by saying I am casting demons out of them and tying them down. Very inhumane, and it's not professional. But can we move on to the next slide, please?
Yes, psychiatric patients are down every issue.
Some people are interfering with what we are saying.
Agobre, Sebastian, can you please mute yourself? Sebastian, okay, that's fine.
Yeah. So what's spirituality all about? It's when we talk about spiritual care, we're also talking about spirituality, and it means different things to different people, and has got wide variety. The diagram here will show you that the Jewish, all manner of the Rosicrucians will say they're being spiritual. They Kanka, the Christians, the Muslims, and so on. So it's a very, very broad area. And when we do in care, from the consultation, we do the assessment. We are and the care plan. We are actually including what the person's beliefs are and the culture. Some people may not practice, but they say, I was born a Methodist. I was born this, I was born that. And it's important to understand what that means to them. Do they want to engage with somebody to talk particularly about some aspects, maybe something to confess, some prayer issues that will come in? Are you the nurse, the right person? I doubt it. You have other patients to see. Your duty is to reflect this particular person's belief on the paperwork you're doing, or in the handover that you're doing. Not mocking, not disrespecting, not actually saying, this person says he's a Jehovah's Witness. Ha, 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 ha. That is not nursing care. That's not spiritual care. Can we move on to the next slide, please? Yeah, so what is spiritual care in nursing? This means different things, as I said, and why. For some, spiritual nursing care looks a plan to offer patient legitimate and structured opportunity to meet his desired needs towards searching for or finding meaning and purpose in one's life. And then I have a quote there, which by Rick Sawatsky and others, and in the Nursing Times in the UK here. And they suggest various approaches. They said that there's the religious approach, the scientific, and the existential approach to that. Those may sound big words, but they are not. You know what the religious is all about. They're not one single approach to dealing with people's spiritual care needs. But spiritual care is intuitive, it's interpersonal, where you ask the questions, you're actually looking for an answer, and you are documenting that, and you are finding out how best you can meet the person's need. Altruistic, in the sense that you are impartial in this. Altruistic, you are prepared to arrange the care and the support for this individual without actually saying that, oh, well, you say you want a Catholic pastor, and we don't do that here. What can I do? You go through the chaplaincy and find out whether they can find somebody who can meet this person's need. That is your job as a nurse. It's interactive, and it's about the patient's own reality. What is their reality? If you want to invite them to your church and so on, that's not being professional. At that point in time, you are usurping their vulnerability. You are actually taking advantage of them. You're thinking it's the time to get somebody who is well off into your church so you can take the tithes and offerings. That's my suspicion. But can we move on to the next slide, please? Now, Kwame Gyekye is a professor of theology in Ghana. Quite often we have the problem, is it spiritual? Particularly in mental health. Is this illness spiritual? And then, but most Ghanaians are religious, and the previous population census showed that Christianity of all shades and colors occupies the hearts of about 72% of the population. And when I come, as somebody who was in the SU, I came through as a Christian, as a young person, and I take very serious issues with Christians who really think Christianity is talk and not action. I take very serious issues a lot. And therefore, if 72% of the population is Christian in Ghana, and there's such huge levels of corruption and inhumane treatment to one another, hardly any trust for one another, Christian nurses can't come together to form a consortium. I'm not saying everybody, I'm not insulting everybody, far from it. But because of lack of trust, because we don't want to, I go to my family house, everybody is reporting somebody to me, and the love is not there, and yet we have a Christian culture, So there are lots of Muslims in Ghana, not too many, but a lot traditional, who I call primary religious groups as well. The others, Hindus, and different types of even secularists. They are in the church. They don't believe anything, but they wear the Christian cloak on every Sunday and carry their Bible. But is the role of the nurse to diagnose or apply therapy of his choice? No, I think I've covered that already in my statement. That's not your role. Your role is actually supporting people to find what will. Yeah, that's check going on there.
Paul Akuba, can you mute yourself, please? Paul Akuba, can you mute yourself? Okay.
Now, what is the next role in spiritual care provisions? Can we move on to the next slide, please? Right, okay. What I consider as in looking at care planning and involving your patient, really involving your patient in the spiritual care and treatment is the assessment, finding out, asking relevant and professional evidence-based questions, applying scientific, behavioral, and healthcare well-being inquiries to build a picture of pathology and impact of ill health, identify real needs and not perceived, not what you think is wrong with the person. First of all, your problem is spiritual. I'm going to tell my pastor. You arrange to meet that person outside work so that you can go and see your pastor. There's a lot of problem with that. If that is part of how you practice your nursing care, or you start your assessment. Now, planning, taking into account information gained through physical, neurological observations, activities, or daily living factors. So you're putting everything together and actually saying that this is what you say you want, this is what you think you're being used to, and we can offer you that, and that is the area. And maybe I'm thinking more of the Western perspective, but I'm also thinking that our textbooks are written in English in Ghana. our studies are based purely on concepts which we didn't design. However, if we can design these concepts and make us competent to practice everywhere in the world, then we need to look at our professionalism and the way we practice care of people. I think our brother has touched on the CCs, which is particularly important. If you're coming to practice in the UK today and you don't have an outer of compassion in you, then don't come. I met an African nurse who happened to be from Nigeria anyway, who was saying that I am going to, if you don't shut up, I'm going to give you injection the way we do it in our country. And actually, I nearly went out there to report her. But you see, the next thing they say is that, oh, we are from Africa, and you don't have pity on this person. You don't know what they're going to lose by getting them to lose their job. That's completely wrong, completely, totally evil, you know. And even if you prayed and you had your quiet time and going to church, to work, and you talk like this, you're not glorifying God. Now, implementation, applying prescribed therapies and managing outcomes, including impacts and side effects, fears, anxieties, and so on. I would not recommend asking somebody to go to a spiritual church or charismatic, whatever name you call it, and be tied down to be prayed for and exorcised without actually seeing what are the first and foremost things you can do to deal with the symptoms and the signs of, if you like, mental illness. I would not, that needs to be addressed, that needs to be dealt with. That you think the person has demons, so you need to tie the person down and exorcise the person. You don't give the person food and no drink, nothing, because he's got demons. Make you a demonic person yourself, demonic practitioner in my book. Now, so when all's said and done, evaluation, through evaluation you learn, through evaluation you know what is working and what does not work. It helps your thinking process. It helps your documentation, your referral, feedback to the healthcare team, and it helps the patient. You help the patient also, even in coming back to recommend you that you did a very good job, if you really care about a good day's job. So these are keys actually to our practice, even in capturing what is essential in health, in spiritual healthcare or nursing healthcare. Can we go to the next slide, please? Well, here you have some references over there that could help you. There are quite a lot, but if you manage to capture some of them to read through, you will be able to have some idea. There's a lot I could have shared with you here, but before I sign off here, let me just read a quote from part of my reading. It said, nurses are increasingly being called on to engage in spiritual care of their patients. A diverse body of theoretical and empirical literature addresses spirituality as it relates to nursing practices, yet there is little consensus about what spiritual nursing care entails. The purpose of focusing on this issue is to conceptualize spiritual care in relationship to nursing practice. A brief historical view indicates that our current understanding of spiritual nursing care have been shaped by three eras, characterized by particular approaches. And of course, I've mentioned the religious, the scientific, the existential. We tend to be stuck with the religious. We have probably very little concern about the scientific, and actually looking at what is worked. The person said, I prayed, or I pray when I have all these issues. Am I going to dismiss it? Am I going to say, well, I don't know anything. I'm just a Christian nurse. I don't know anything about the science, and the science don't work. Or am I just going to sit down there and think, well, I don't believe these things, and I can't be part of it. If you don't believe, recently we took a family member to while I was in Ghana between January and March, to meet a healthcare practitioner who said he was doing herbal, and the first thing he does is to pray and talk his usual religious jargon, and yet the amount of money he was asking and the pathway to treatment of cancer was purely exploitative, was purely to make money, and so on and so forth. And we saw the signs. We knew this was not okay, false. Thankfully, some treatment have taken place at the Kolibu, and the prognosis is very, very good as I speak. But there are a lot of dangers when it comes to dealing with spiritual care of patients in our society over there. And we need sharp improvement. We need sharp understanding. We need actually ask God whether we are doing His will. If nursing care is one of the callings that you have to honor God with, then think again. With the attitudes that you show to the patients in the area of psychological, physical, and spiritual. I stop here, and if there's any questions. Can we do the next slide, please?
Thank you very much, Pastor Henry. I think this is also deep. We have learned a lot. As healthcare professionals, we can never underestimate the physical care or needs of our patients. That is good. I am not supposed to actually add and also to conclude on certain things because it's quite anecdotal. But in Africa, specifically in Ghana, I think because our patients' spiritual needs have often not been met, people take advantage of them. They come to the hospital. For them, they think that the spiritual beliefs that they have should also come to play so that they get healed. But as healthcare professionals, we undermine that. And so they get out there and get crooks who take advantage of them as a way of trying to help them solve their healthcare problems, but they rather exploit from them. And as professionals, as Pastor Henry has just said, we have to take the health needs, the spiritual needs of our patient also as an important factor as far as healthcare services is also concerned. Thank you very much. We have some few questions in the chat session. I don't know if we can read some out for clarification. It says Winifred Kusi is asking if it is right to start the day at work by praying with the patients and sharing the word of God with them. This is a practice that mostly go on at various OPDs in our hospitals in Ghana. So she wants to find out if that is right.
Well, thank you very much. That's a very important question. But I think it's a culture in Ghana, and I'm not going to knock it. I'm not going to say it's not right. But fundamentally, if you want to go by, if you like, a human rights thing, then you can say there's a problem. The reality is that if you start by saying to the patients that this is what we're going to do, you have a choice to sit here or not to sit here, and we're not going to be prejudicial or discriminate against them because they didn't sit down to listen to your Bible reading or anything, then I would not knock it. I'll simply say that, yes, they are vulnerable. They've come. We can take advantage of that. We can abuse them if we want. You can look at it from all those angles. But on the other hand, haven't read the Bible to them, haven't preached at them, am I going to treat them well? That is the question that I will ask. Will I be the next person the next nurse who will be sitting down there by the doctor's office, waiting to swap different people's cards, and here and there, those who are giving me money and all those things would actually reflect the biblical reading that I've done? It's a question we have to ask in checking the culture that we have over there. But for me, I think there's a lot of problem. When I come to Kolebu, which I have not come very often, thankfully, I've hardly actually been a patient in hospitals. I'm very stubborn, and I would, if I have to shout at nurses, I will. But these are the things that you look at and you think, why? Why do we do these things? Yes, there's a lot of, somebody said, I think I'll stop there. Let me go on to the next question if you want me to.
Okay, so Dominic wants to find out, Dominic Anyoka.
Pastor Henry, can I just pop in there? Because
yes.
Okay.
I know that we are going to talk about those who want to come to England. It's no in England for you to preach, to pray with a patient. It's no. You will put yourself in real trouble. So if you are coming to England, please drop at that culture at the airport. Please. Don't bring your spiritual that you are praying with patients, you are reading the Bible. It's no in England. So unless the patient asks you voluntarily, and you need to talk to your manager before you do that.
Exactly.
So in England, all these religious what they call it, we put it in ourselves. You can't do it. You can't read the Bible to patients, although there's a Bible on the wall.
Yeah.
For those who are Christian, because Christianity in England has different dimensions.
Yeah.
Okay. So the reason why I'm saying this because later on they're going to talk about those who want to come to England. Please, when you are coming, your religion should be in your pocket and your suitcase, and don't bring here, please. Thank you very much.
Okay, thank you. The question asked earlier, have you gone past it? Sorry.
So Dominic, yes, Dominic is asking. It says that talking about anxiety, fear, and so on, patients are sometimes rushed into health facilities, especially in emergency or acute care, by relatives with so much anxiety and fear of the outcome of care of the patient.
Yeah.
As far as spiritual care is concerned, can the nurse encourage them to rather pray instead of the former? So once the patient relatives are anxious, can we encourage them to rather pray than being anxious? Is it right to encourage them to engage in prayer?
Well, again, it's a cultural thing. The issue there is that what comes first? The assessment to know the kind of right treatment that the person will have to come, and showing confidently to the patient that we are here to help you, support you, or we want to engage in, if you like, spiritual battle with them, or spiritual chess. Can we pray with you? Can we? Well, in Ghana, the grace of saying, by the grace of God, God will help you. It's common. It's cultural. Nobody takes offense if you say that. You can say that to the Muslim or anybody, and everybody says that. So I'm not going to say change it, but I am trying to say we must mean what we say and say what we mean in all the situations. Yes, in emergency situation and so on. I think one of the great things Christians do with the Holy Spirit in them is you can pray without being noticed. And that prayer still can be effective. So it's not the outward show. Jesus taught us about that, of prayer and all that it stands for. And not everybody is actually praying the right prayer anyway over every patient. So that's my view on that. Thank you.
Thank you very much. Thank you very much. I think somebody is asking another question that, please, how do we meet the spiritual needs of our patients when you, the nurse, is not allowed to engage your patient in religious conversation, as you rightly said?
Well, I said clearly that the spiritual, when you do the assessments, you document that. And I think it's been already said that if the patient gives you the permission, my issue is that how many minutes have you got? How long have you got to spend with your patient? And are you going to kneel down or ask the patient to kneel down? You pray for him because you believe that is the cure for his illness. And have you documented that in your nursing care, nursing records, that is what the patient wants or is expecting you to do? And is that something you can hand over to everybody? You need to be very, very professional in this issue of spiritual, knowing the spiritual needs. To say, how do we meet the spiritual needs? I think what I have said all along is that coming to pray with the patient is not what's meeting the spiritual care of the spiritual needs of the patient is. It is not what it is about. You can't pray. You can also take their problem home and go and pray with your family or with your church. Don't simply try to be over religious, over zealous, trying to show off your ability to pray, for the next 5 minutes, praying to take out the demons that has caused the illness. I don't think that is the way to go. Have I answered the question?
Yeah, I think that was well answered. So someone wants to find out. That is the name is David Anamo. He says a Jehovah Witness child had low hemoglobin level, and the patients refused blood transfusion. The parents refused blood transfusion. Is it right to allow the child die of anemia? And in a situation like this, how do we handle it?
Well, I wonder what the law books say in Ghana in terms of the human rights of the child. In the UK, it's a straightforward issue. And that can be dealt in the courts. The social services can come in straight away. Sister Sylvia can talk a little bit more about that because she works with children and under 5. But in Ghana, I know when I was growing up, there was social welfare and they did something good. But these days, you can put money in the hands of everybody and they shut up. Even postmortem is not done for everybody because even when they were killed at home, because it's either we religious it, spiritualize it, or we actually bribe somebody not to do the postmortem because if they do it, they will find out the truth. I'm talking real things. I'm not just throwing words about because that's my experience in Ghana. So, but what I'm saying here that this is a serious matter. That parents have a right to have a children look after the children, but the professionals also have a right to care appropriately for the needs of the child, and that has to be dealt with, legally.
That is fine. That is fine. I don't know if Auntie Sylvia is still with us. Auntie Sylvia, please, are you still with us?
Yes,
okay,
I'm
can
still
you please
here.
clarify in some few minutes? Yes, clarify in some few minutes what in a situation like that you do in the UK.
So normally there are other transfusions that will be offered to the parents, and if it's severe and action has to be taken, then it will be a safeguarding issue that the hospital will come in and they would act in the best interest of the child. So which means they would override the decisions of parents and they will step in. Yeah.
Okay. As much as I also know, I think that is a similar thing that is done in Ghana also. Once it's a child, a minor, the facility, the hospital can just take charge and decide on what would best help that patient as a child. So I think it's a similar situation here in Ghana. So I don't know if some other practitioners have other things that may contradict what I have just said. But I think
honest, in England, when such case happen, based on religion, we have the law that the hospital can go to the court of protection. You understand? And take over the care of the child from the parents. So the court of protection will give the hospital the power if it becomes life and death, because we have the laws in England say you have it's your duty of care to protect life, to preserve life. In Tunisia, all this is not accepted. So what my colleagues have said is true, and you have said, but we have higher court in England who can give the hospital power to take the power from the parents in total. That is the power from the court of protection. Thank you.
Okay, I think that is a good one from Pastor Michael, because you have also helped us learn about what is even happening in other countries, like you rightly said. So I think we will continue to learn more as we add you to the page. There are lots of things that as practitioners we need to learn, and we are just hoping and trusting that we'll be able to tap into your rich knowledge. For now, we would want